morning, everyone. My name is Dr. Kevin Ford. I'm a member of Omega Psi Phi Fraternity Incorporated Gamma Pi chapter and a member of our Health Initiative Committee. The Health Initiative Committee, during the midst of the pandemic, would like to encourage everyone to still be vigilant about social distancing, wearing a mask, and get your vaccine when it's your turn. We know that the numbers are going down, but we still need everyone's help to try to decrease the numbers in this pandemic. This month, though, this webinar is focusing on National Kidney Month. And we're honored today to have the executive director of the National Kidney Foundation, Ms. Patty Dash, to give us a few words about kidney disease. And so we just want Ms. Dash to come on and give us a few words.
Thank you so much. I want to impress upon you that 37 million individuals are impacted by kidney disease. I want to thank you all for inviting the National Kidney Foundation, serving Maryland and Delaware, along with our partner, University of Maryland Transplant Center, today. My name is Patty Dash, and I'm the Executive Director for the National Kidney Foundation locally. March is National Kidney Month, and as we have been celebrating all month and all year, we appreciate and understand why health equity is so important even more today due to the pandemic. Reducing health inequities is important because health is a fundamental human right, and its progressive realization will eliminate inequalities that result from differences in health status, such as disease or disability, in the opportunity to enjoy life and pursue one's life plans. So I'm proud to say that in February, our national office launched the first ever Health Equity Advisory Committee, who's responsible for directing and championing NKF's health equity. Together, I know that we can make a difference, and I know that this committee is going to be very vital in the months and years to come. So again, I said kidney disease affects an estimated 37 million adults in the US and can lead to life-threatening kidney failure. Most of those with the disease don't even know that they have it and won't until it's progressed to a critical late stage. People of color, including Black, African American, Hispanic, or Latino, an American Indian, an Alaska Native, Asian American, and Native Hawaiian or other Pacific Islanders, are at increased risk for developing the disease. So we want to make sure that we get our education across and that we together make the difference in today. So again, 37 million people are impacted with kidney disease. This is why health equity is so important. Thank you.
And thank you, Patty, for giving us those words. And speaking of chronic kidney disease, we have a person today, Miss Antoinette Corbin Taylor, who is dealing with chronic kidney disease. She's a member of Delta Sigma Theta Sorority Incorporated, and also the wife of a member of our chapter, Brother Teddy Taylor. So, Antoinette, you can give us a few words.
Good morning, and I want to thank Gamma Pi chapter for allowing me this opportunity to speak, because every chance that I get to speak about it, I want to take advantage of it. As Ms. Dash said, I am one of those persons who really did not know that I suffered until my state of kidney disease was very severe. In a way, I had an idea because of the nature of what I did for my career. I'm now retired. I would have to go through periodic medical exams because I was in the Foreign Service and served overseas, and so I had to get a medical clearance. And in one of my exams in 2013, it did indicate that my kidney functions were not optimum, but I began monitoring my diet, and I had to take Tums, which to me was kind of strange, but the doctor prescribed Tums. That cleared up. I got my medical exam, and off I was to my overseas assignment to Uganda for 4 months in 2014. And at the end of 14, I Went through I actually went to, my husband was posted in Cape Town, South Africa, and I went to spend Christmas there. And a very serious bout of what felt like to me flu. But I ended up in the emergency room, in the hospital, and in intensive care for 4 days, including Christmas Day. And what had happened was that my kidneys had basically shut down completely. And the doctors had indicated that had I not come in within about 72 hours or so, I might not be here today speaking with you. Fortunately, at that time I was put on dialysis, and I was very fortunate that within a month, my kidney function recovered sufficiently to the point that by the end of January of 15, I was taken off dialysis, but continuously monitored. But unfortunately, at the end of 15, I had another bout of dehydration. And again, my kidney functions went down. And at that point, I was on dialysis and have been on dialysis since late 2015, November of 15. I had been listed on 3 different transplant lists. And in August of last year, I actually did receive a transplant. During that more than 4-year period, my kidney functions were such that I did not urinate during that time. So with the new kidney, I began the process of urinating, and was very pleased. Unfortunately, my kidney, the transplant, it's not that my body rejected, but it was not cleansing sufficiently. So I still had to maintain dialysis. They lessened my dialysis, but I could never completely go off of dialysis. And I'm at a point now where I have actually been relisted because it's been made a determination that the transplanted kidney is not functioning sufficiently enough for me to not have dialysis. And so I have been relisted. I say all that to say that I am still extremely optimistic. I am extremely grateful for the fact that there is a possibility, and I just want to advocate for anyone to consider being a donor. I did make appeals to my family and friends. Unfortunately, my family's members have different health history issues that did not make them candidates for donation. But for anyone, please monitor your health, but also consider being a donor. Thank you very much.
Thank you very much for that story that you just gave. And we know it's important for everyone to try to help in donation of kidneys. And we're going to follow that up with a nephrologist in our community, Dr. Biari Osman. And Dr. Osman is board certified in internal medicine and nephrology. He did his nephrology fellowship at George Washington University. He's currently practicing in Prince George's County and has several offices in Glendale, Maryland, and Upper Marlboro. So Dr. Osman, if you can come on. Thank you.
Good morning, all. First of all, I'm gonna be very grateful for the fraternity for inviting me to give this very important talk because chronic kidney disease really is ravaging our community, and it's very nice that we go out there and educate as much as we can our brothers and sisters about this disease. Just like the last speaker said, before it gets to the last stage where you really can't do much other than dialysis or kidney transplant. I'm going to start sharing my screen so you can see topic of my speech today. Okay. All right. Okay. So first of all, we need to have a little bit of idea of what the normal kidney function does. Okay. The normal kidney works 24 hours, 7 days without a break. So you can imagine when your kidney fails, what happens to the body. So some of the functions are the medications we take, they are detoxified in the blood, and about 24, the kidney gets about 25% of cardiac blood coming from the heart. So you can imagine all the blood flowing through the kidney. So the toxins have to go through the kidney. So when your kidney fails, toxins build up in the kidney. Also filter waste from food product we eat, and excessive fluid removal. That's a major function of the kidney, and it's the key organ in blood pressure regulation. So you can imagine when your kidney fails, you can't get rid of water, you can't get rid of salt, you increase your volume in the blood, your blood pressure gets higher, you have more damage, it becomes a cycle. So that's just as long as you can understand the function of a normal kidney, you know what a failed kidney can do. Also, kidney produce some chemicals that help promote red blood cells called erythropoietin. So some patients, when they get to advanced stage, even when they get to a moderately severe stage, like a stage 3, there's a reduction on these chemicals. They start getting fatigue, anemia. They'll say, well, you don't know why you're fatigued. It may be kidney disease. And they also do a great job as producing active vitamin D that helps you absorb calcium from the gut. You can imagine if your kidneys are not working well, your calcium level is low, risk of bone disease, and everything else that may even affect your heart. So once you have an idea of what a normal kidney does, you can picture when kidney fails, what may happen to somebody. Okay. Now, I will minimize this if you don't mind. Chronic kidney disease basically refers to abnormality in kidney function or structure that has been going on more than 3 months. Sometimes the kidney function may be normal, but you have a structural problem. Maybe your doctor does your urine and find protein or blood in your urine. That's a damaged kidney, something else is going on. That needs to be investigated. As you've all heard, chronic kidney disease affects about 15% of US adult population, about 37 million people. Most of them are minorities, African Americans, Latino, Hispanics are stated. So you can imagine how this affects our community. And on a global scale, look at about 1 in 5 men and 1 in 4 women over the age of 65 affected with chronic kidney disease. Okay. Basically, the definition is that when it's chronic, the kidneys are no longer capable of doing their regular function, like I just stated. The number may still be normal, but the structure may be bad or completely failed when we call it end-stage kidney disease that you need dialysis or kidney transplant. All right. So you have several stages of chronic kidney disease, 5 stages. You see how you progress from normal and then the other 5 stages. It does not necessarily mean when you are at one stage, you have to progress to the other. Because if you are discovered early, you can stabilize the function of that kidney that you don't progress. Or whatever etiology that is causing the kidney disease can be taken out and then you just stabilize, you don't progress. It does not necessarily mean, it just means that if not well taken care of, you eventually progress with kidney failure. The question is, how do you know your stage of chronic kidney disease? We have what we measure or calculate called estimated glomerular filtration rate. What this means that it tells you how much function your kidney is giving you, so that you will know what stage you are. How to calculate it by your doctor having the blood drawn, and there's a substance in the blood called creatinine. From the creatinine, they can apply that to your age, your sex, and your risk. Currently, we're trying to take out race as a measure of determining estimated kidney function, because we're realizing that we are missing some African Americans because we may be overestimating their kidney function by using race. So, but the work, this is still in process to give us a better calculation to be able to capture a lot of folks that may have chronic kidney disease that need to be attended to early in the progress, so that we can arrest these before it gets to kidney failure. All right. So these are the stages you have. Sometimes we call them the glomerular filtration rate is expressed as ml per minute. That's milliliter per minute. But sometimes your doctor may say you have 20%, you have 30%, because we use 100% as more like the normal, but normal may be between 90 to 120 ml per minute. So when you go see your doctor may say your kidney function is about 20%. So this is what it means. So you can see stage 1 is essentially a normal kidney function. It may just be because there are abnormality in structure, like protein in the urine. Anything above 90 ml per minute is stage 1, but you may have red blood cells in the urine, you may have protein in the urine. That kidney is not normal. Whereas stage 2 is also relatively mild damage with decreased function, is between 60 to 89%. Stage 3 recently divided into 2 stages. You have the high stage 3, which you see there, and then you have the low stage, the 3B, 30 to 44%. Now, when you get into stage 4, now we're having severe kidney damage with decreased estimated function. And by that point, even before that point, you should be thinking what needs to be done when you eventually get to kidney failure, which is stage 5. That means your function is now less than 50 ml per minute, or we may tell patients this is less than 15% of normal. So which means when you're less than 15% on normal, what we're thinking about now is what do we do? You should already have an idea before you get to this point. Sometimes we get some people in the emergency room that they just, at this point, we have no time. As another speaker said, that's just emergency dialysis at that point. What we try to prevent is emergency dialysis or emergency kidney replacement therapy, because when the patient is well prepared, over time, really you just the lifespan is much longer compared to somebody that just crashes to the emergency room with kidney failure, right? And that, why do we need the stages? Like I just told you, why is it important? It's important because you can look at all the risk factors that you may correct that helps you reduce your progression, like your blood pressure control, diabetes control, making health lifestyle changes, so eating right, because sometimes, yes, you have a lot of people who are in a food desert, but they need to understand how all these calorie dense foods, all these fatty foods, all these fast foods, alcohol consumption, cigarette smoking, sedentary lifestyles, obesity, how it really ends up affecting the lifespan. By the time they get to be noticed, most of these damages have been done already, that now we're just like a Band-Aid. That is most of the reasons why we have the lifespan cut short, because the preventions were not taken care of at early stages. And then you're able to get education regarding your diet that may incorporate your diabetes, because diabetes and hypertension are quite common major causes of chronic kidney disease. So sometimes it's very difficult to craft a diet that does not exacerbate your diabetes, but that's what the role of a dietitian that helps you. And then you get more education of compliance. Reason people sometimes don't know why they are taking medicine. They don't ask, why am I on this medicine? They believe the medicine is just, they don't take them on a regular basis, or they just take them when they think they feel sick. So this is very crucial. Somebody say, well, I've been taking it, but my blood pressure is better, I don't need it anymore. Yes, you may stop your medicine, but give it another month, your pressure will be off the roof. So these things are education is very important when patients come early into notice that we can advise them and help them as well. These are the several risks for chronic kidney disease. As I stated, you can see hypertension and diabetes account for about 70% of a patient with chronic kidney disease. Practically, you have almost 1 in 3 adults with diabetes have chronic kidney disease. So you can imagine 1 in 3 adults in this country have one form of chronic kidney disease. And most of those patients are minorities, African Americans and Latinos, all right? And about 1 in 5, and 1 in 4 to 5 have hypertension. Also, most of them are minorities. So these diseases are really very important. People need to pay attention. Don't say, oh, I don't feel sick. I see that mostly in a lot of our men. I'm fine. There's nothing wrong with me. I don't need to see the doctor. Yes, you need to see the doctor, or even just to tell you everything is come back next year. That goes a long way than missing you in the emergency room. Of course, you may have people, once your family history of diabetes, hypertension, heart disease, kidney disease, you need to pay attention. Of course, I talk about heart disease, and most people older than 60 years old, we have a lot of chronic kidney disease. I think up to 35% of people above 60 years old have one form or the other of chronic kidney disease. As I stated, you have the race, African Americans, Latinos, Hispanic. Excessive use of over-the-counter medications, especially young men, adults playing sports, they pain all these injuries without paying attention to what they are doing to their bodies, taking a lot of these non-steroidal anti-inflammatory drugs. If you use them in reasonable amount, that's fine. But again, when you use them, make sure you don't have underlying chronic kidney disease, because they can worsen your chronic kidney disease. And then excessive use of acetaminophen also have been shown to cause kidney damage. So you really need to pay attention to over-the-counter medications that also may cause chronic kidney damage. Then you have a chronic strict drug like cocaine. Of course, we know what that can do. Can cause vascular damage leading to uncontrolled hypertension that may also damage your kidneys. And then common genetic disorders in the society like polycystic kidney disease, where you have a lot of cysts, crowded normal kidney function is not uncommon in our African American population. This has most of the risks that you have glomerular diseases that are not here, and then you may have some infection too, leading to chronic kidney disease. Okay, how do you know you have chronic kidney disease? Again, you have to have your visit to your doctor. This may be determined based on your condition, maybe annually, it may be quarterly, it may be semi-annually. So by having your blood work drawn and then asking questions from your doctor, your doctor have a right to tell you, explain what your blood work says, so that you can be well informed. By asking questions and understanding what it says, that you be well informed and ask further questions. Again, symptoms of chronic kidney disease may not be apparent at an early stage. By the time you realize it, it may be late. Time for dialysis, and even that may cut that person's life short. Some of the symptoms, these are not limited. You have blood pressure that's now poorly controlled because your kidneys are not working well. Now you retain a lot of fluid. Your blood pressure goes high again. Again, that's a cycle. You could have what they call diabetes honeymoon, because the kidneys, as I stated earlier, help to filter some drugs and toxins from the blood. They also help to get rid of insulin byproduct, so that when your kidneys are not working, you have a lot of circulating insulin in your bloodstream. So you may think, oh, I don't need insulin anymore. I don't need diabetic medicine anymore because my sugar is now normal. No, it may be your kidneys are going down. So that should bring your attention to find out what's going on with you. You may have swelling of the legs because now the kidneys are retaining salt and water. And fatigue, just like I said, changing your urine output, maybe waking up multiple times at night to pee, may be a sign of chronic kidney. I'm not saying 3 or 4. I'm not saying after drinking so much water. Just that you doing the normal thing of your life, the normal daily activities, and then you have to wake up multiple times at night. You need to check what's going on with you. By the time we see all these symptoms in red, poor concentration, you know you may be an advanced stage that the only choice is for dialysis at that time. Now, these are just graphic pictures of what you may experience with advanced chronic kidney disease, the tiredness, loss of appetite, swelling around the eyes, shortness of breath because fluid builds up in the lungs, and itching from the toxins that are deposited on the skin. And your urine may bubble from a lot of protein. Hello? Your urine may be bubbling because of a little protein in the urine, and you may have a sleeping difficulties. All right. So now the management of chronic kidney disease, when you get to end stage chronic kidney disease, that is beyond stage, that's stage 5 beyond. These are the management that's we call end stage. It could be dialysis, and this is the reason why sometimes when you are about stage 4, upper stage 4, even stage 3, these days, stage 3, we tend to refer to stages 3 and 4. When you come to our notice, we refer you to what is called a chronic kidney disease class. There you get more information about preparation for kidney replacement, diet, management of your condition like blood pressure, diabetes, and then at that time you're making your choice what you would like done when you now get close to kidney failure or kidney failure. So if it's dialysis, you have the home dialysis, which you can do at the comfort of your home. These days, a home is the best place to be. So you could be home hemodialysis or peritoneal dialysis. And this would need preparation in terms of what kind of assets you use to get your dialysis. Then you have the dialysis you do in center if that's your choice. But the most important is to get prepared. You don't wait till you need dialysis. You've been preparing since about stage 3, especially 3B down. You've been preparing. Of course, the ultimate is kidney transplant. So either identifying somebody who may in your community, family member, friend, neighbor, who there's no shame in telling somebody I have this condition, because you may not understand, who want to donate the kidney to you. Because somebody may be in their mind, they want to donate to somebody they don't know, and they may hear you talk about your disease and they just want to donate to you. And if you don't have any of those, you can always be listed. Even before you get on dialysis, you can always be listed for a cadaver donor, and so when you start dialysis, you're already listed. But again, it's not just getting the transplant, it's getting well prepared before the transplant. When I mean well prepared, your underlying conditions are well taken care of, so that you get yourself seamlessly into these processes with little or no complications. We have people in our office that we've seen that have been a transplant for 20 years plus. Even from cadaver transplant, 20 years plus. Their function are very good. We have older people, almost 88, 90-year-old with a living donor transplant with minimal medication. They're still doing very well. So the key is to be well taken care of before you end up needing all these therapies. Currently from the last USR United States data, you have about almost 550,000 people on dialysis and 230,000 people with a normal working kidney. So you could see that in the African American community, you have about 3 to 4 times higher than the Caucasian with end-stage kidney disease. So this is very important that we manage chronic kidney disease properly well, so we can reduce all these prevalence and incidence of people on dialysis or advanced chronic kidney disease. So in summary, chronic kidney disease is very prevalent. It's just the only way you know is just to get evaluated. And with increased risk for those, as I stated, hypertension, diabetes, African American community, older age, and eventually may lead to end-stage chronic kidney disease with reduced lifespan, especially if not identified early in the course of chronic kidney disease. This is just, so get tested. If addressed early, you can modify this disease to reduce progression, and if it progresses, to get prepared for what to do when you get into kidney failure. These are just credit to where we got the videos from. Thank you so much. This is what this has been very informative. Thank you.
Thank you very much, Dr. Osmond, for your informative talk. And next up, we're going to have Dr. Z. And Dr. Z is a transplant surgery fellow at the University of Maryland. Dr. Z went to medical school at the University of Toronto, did residency at Western University in London, Ontario, and research interest is improving access to renal transplantation for disadvantaged patients. So I think that is a timely discussion. Hopefully we'll have today. Dr. Z.
Excellent. Hi, guys. So I'm Dr. Z, this is Dr. Barakas, and we're both from the University of Maryland. And we're here to talk to you guys about kidney transplantation and how that is the best course of treatment for chronic kidney disease and kidney failure. So let me see if I can share my screen correctly here. I think this is okay. All right, so let's do this. So just some disclosures that the University of Maryland is a partner with the National Kidney Foundation, serving Maryland and Delaware, and Dr. Silke Nierhaus, who's one of the other transplant surgeons at the University of Maryland, is a board member, and she helped us prepare some of these slides. And so some of our part of our presentation will overlap with Dr. Osmond's talk. So we'll kind of briefly go over these things again. In terms of kidney failure, there's a lot of different causes for kidney failures, and the most common ones being diabetes and high blood pressure. Now, as Dr. Osmond already said, there's varying degrees of kidney failure. If you catch the cause of these kidney failures early, especially diabetes and hypertension, and you control them well, you may not progress into chronic end-stage kidney disease, to which point you may need dialysis or a transplant. There's other causes of kidney failures like glomerular disease, which is essentially diseases of these little filtering units of the kidney. There's hereditary causes like polycystic kidney disease or other causes that you're just born with, and even renal cell carcinoma or renal cell cancer, and treatment for kidney cancer that can cause kidney failure. Now, at some point, your kidney failure may progress, and your glomerular filtration rate, or how we measure how well the kidney is working, becomes very low. And at less than 20, you may have a discussion with your nephrologist about getting some sort of treatment, either dialysis or transplant. Now, we've already discussed the different types of dialysis, hemodialysis and peritoneal dialysis. And very rarely, because the treatments have been so good these days, people will get offered palliative care, meaning they don't progress to any certain type of treatment. But because the treatment is so good these days, that's only offered to the sickest of the sick people. So just briefly, hemodialysis is essentially using a machine to help clear your blood, and that can be done at home or in a dialysis center. And essentially, by placing a AV graft or arteriovenous fistula, blood is drawn out and is put through the machine. The machine clears the blood and then returns the blood back into your bloodstream. Very rarely people go under dialysis using a dialysis catheter, but long-term use of these catheters are bad because it causes blood vessel problems. Hemodialysis is done typically 3 to 5 times a week for 2 to 4 hours at a time. So if you think about it, the overall amount of time that is spent on doing dialysis is quite significant, and that can really impact somebody's quality of life. There's also other complications of dialysis, including infection and then pseudoaneurysm of the graft or fistula, meaning these balloon dilations that cause that could potentially have other complications like rupture. And very rarely there's clotting and thrombosis.
It should be noted here that when we're talking about fistulas or grafts, both of these are under the skin. So you can take a bath, you can go to the swimming pool, so you actually lead the normal life. Whereas with the catheter, the problem is that there's a piece of plastic that has to be connected to the machine. It's associated with a high rate of infections. And that's why we're saying that the catheters are bad, and we would always promote the fistula and graft.
For peritoneal dialysis, this is typically done at home. And that is done by using a catheter that's implanted in the belly. You use some dialysis fluid that gets infused once or multiple times a day, and using the lining of inside your abdomen, that can draw out toxins from the blood. And then when the fluid gets drained, the toxins get drained out with the fluid. Again, with same problem with the hemodialysis catheters, there's always problems with infection. There's problems with the catheter kinking or clogging. And then sometimes that can be a problem moving around. So again, that's not the most ideal way that we would want your chronic kidney disease to get treated. So why do kidney transplant? So with a kidney transplant, you are free of any machines, whether it be a hemodialysis machine or a peritoneal dialysis machine. You get to avoid the 2 to 4 times a week of dialysis and live a relatively normal life. You also get to avoid the complications of dialysis that we already talked about. And we know that a kidney transplant helps individuals live a lot longer than any form of dialysis can ever do. And so for kidney transplants, there's a lot of different options. We always promote living donor kidney transplants because that's the best. And by best, we mean that helps people live longer, but also because the grafts themselves last the longest compared to any other kind of deceased donor kidneys. There's also a wide variety of deceased donor kidneys, and we'll talk about each of them a little bit over the next few slides. There's kind of the average type of kidney transplant, but then there's also higher KDPA or kidney donor profile index kidneys. That basically means that the donor themselves may have had other medical issues in the past that may make the kidney not last as long. There's other donors with infections in the past, hepatitis B and hepatitis C, which we are able to use safely, and we'll talk about why, and how there are certain donors that are deemed at public health high risk or increased risk for transmitting diseases.
Okay, and when it comes to the point of living donation, we are saying that this is the best choice for you, is the best quality kidney that lasts longer and gets you off dialysis straight away, because it does work straight away. Whereas with the waiting list ones, you can get a very good kidney, but this is sometimes a bit of a gamble. We're not sure 100% when the kidney is going to wake up. It could take some time, meaning sometime it could take a few weeks for the kidney to wake up. But for the living donation one, imagine you get the kidney from someone who is going to live lifelong on one kidney. So you get a perfect quality kidney.
And some of the other advantages of a living donor transplant is that it can be a planned surgery. You work with your transplant team to set the time and date. It's during the daytime so that there's a lot of people around to help watch after you. And again, the kidney works immediately. You get off dialysis almost immediately, and the kidney always lasts longer. compared to deceased donor kidney transplants, essentially the amount of time that you're waiting for your living donor transplant can be a few weeks to months, depending on how fast both you and your donor undergo the workup process. In deceased donor transplants, some people, and depending on which part of the country you're living in, some people can wait up to 7-8 years for a deceased donor transplant. So that's a very large amount of time that you're waiting. And in terms of looking at ethnic access or variability in access based on ethnic groups, we know that African Americans are at higher risk of kidney disease, and there's a larger number of African Americans on the waiting list, but the percentage of donors who are willing to donate are disproportionately less African American. And there's been a lot of research looking into this, and a lot of it has to do with knowledge and knowing how to ask somebody about a living donation. So in that line, our next big event called Big Ask, Big Give is talking all about living donation. So if you are interested, Patty Dash, who is on this call, is helping organize this. And I think there was just a link sent out in the chat about it. So please sign up for it. The event's tomorrow at noon, I believe.
Correct.
So about deceased donor kidneys, though, an average kidney from a deceased donor lasts about 9 years. And like anything, like anything else in your body, the better that you take care of it, the longer that it's going to last. So you have to make sure that you still take your medications. And after deceased donor transplant or any kind of kidney transplant, you have to be sure that you take your immunosuppression medications. And you have to make sure that you get your labs drawn because over time, we have to continue to monitor your kidney function. And with some of the medications, we have to monitor the level of medications in your bloodstream so that we know that you're getting the adequate dose. And that can prevent rejections, and that can prevent the kidney from failing earlier than expected. These higher KDPI donors that we were speaking of earlier, so these donors may have had hypertension, diabetes, but not to the degree where we think that it would have affected their kidney functions to the point where it wouldn't work. So if we look at these donors and we think that their kidneys are still working well, we can still transplant them. But it's kind of like getting a quote unquote used car. And it's not, it might not kick in right away. And you may still maintain dialysis until it kicks in. But typically after a few weeks, the kidney will regain some function, and to a degree that it can get you off of dialysis. These kidneys may require more maintenance and we may need to adjust your immunosuppression accordingly, but they are expected to last at least about 5 years. In terms of donors who previously had a history of hepatitis B, people can get hepatitis B from these donors, but the risk about that is about 1 in 1,000. And if you're vaccinated for hepatitis B, the risk is even lower. And if you haven't been vaccinated for hepatitis B, we would give you a medication after transplant to reduce that risk of transmission. And using these donors is a strategy that we have been safely using to decrease the amount of time that an individual waits to get a transplant. Hepatitis C positive donors is something that we've been using over the last few years. It's still relatively new, but this has been a very good option for transplant recipients since the treatment for hepatitis C has improved over the last few years. Now, previously, we wouldn't consider using these donors because transmitting hepatitis C also has significant consequences. But because nowadays, the newer treatments for for hepatitis C works 99 out of 100 times, or even better, with minimal side effects and only for about 12 weeks of treatment, the benefits of using these organs means that the recipient can get a good functioning organ, get the virus, but get it treated, and then still get to keep the kidney afterwards. The risk is that if the treatment doesn't work, then there's a very rare chance of liver failure. But again, that's kind of less than 1 in 100 times. The medications for treatment of hepatitis C can be costly, but from our perspective, we have not had any problems of getting these medications covered by the proper insurance companies. And now just a little bit about the PHS increased risks. Now, these are donors who have had a history or something in their history that puts them at increased risk of transmitting certain diseases like hepatitis C and hepatitis B. We do assess every single donor for these conditions, but if the donor recently acquired these diseases right before donation, the tests that we have available may not be sensitive enough to pick it up. So some of these behavior could be as benign as living with somebody with hepatitis B, but it can also be something like IV drug use or having unprotected sex with somebody who had a history of injecting drugs for non-medical reasons. Now, a little bit on how kidney transplant is done. If a kidney were to become available for you, we would call you to the hospital. You will undergo surgery. The new kidney actually gets implanted within the pelvis onto the vessels, blood vessels there. And we leave your native kidneys alone. There's 3 connections. There's arterial connection where the blood vessels goes into the kidney. The blood gets filtered by the kidney and then is drained from the vein. There's a 3rd connection where we connect the ureter, which is the tube that drains urine that's made by the kidney into the bladder. There's typically a little plastic stent that gets placed in to help heal the anastomosis. The stent is taken out by our urologist colleagues in about 3 to 4 weeks' time using a little flexible camera. We just always make sure that there's good blood flow, and typically after surgery, you stay in the hospital for 3 to 4 days after we made sure that your eating, drinking, and pain is well controlled and you're able to move around. There's a lot of new medications to learn after a kidney transplant. We make sure that you know what they are, and over the few weeks after kidney transplant, you'll follow up with us in the clinic so that the medications are reviewed. We make sure that the medication doses are correct. You may feel a little sore, but that will improve over time. And as the time goes on, your visits with us will draw out as long as your medication levels are stable and your kidney function is stable. There are obviously complications with any kind of procedures that we do. Some of the common ones include numbness on the thighs, a seroma, which is seroma and lymphocele, which is essentially fluids that get built up around the kidney after the transplant. And that's a reaction from the inflammation, as well as some of the surgical cuttings that we do. There is a possible for urine leak, and that's the connection between the ureter and the bladder not healing appropriately, and that may require a longer period of time with a stent or a catheter. Other complications could be a ureteral stricture, meaning some part of that ureter tube scars down, and that may require a secondary procedure or a surgery. You could get scrotal swelling, and we will continue to monitor you for rejection, as well as other surgical complications like hernias that may require secondary procedures. The other thing that we ask everybody to monitor after kidney transplant is skin cancer, because that increases, the risk of skin cancer does increase, and you have to remember to wear sunscreen at all times afterwards. Some of the more rare complications include blood clots within the vein and the artery of the kidney. That will require some procedure to clear up the vein, clear up the clot. There could be recurrence of your original disease. Depending on what your original disease is, sometimes people can get the disease back over time. Some people may very rarely get the disease back right away. But that doesn't mean that you go back on dialysis right away. That just means that we have to continue to monitor you. And otherwise, there's risk of bowel injury, which is a part of the surgery, as well as injury to some of the arteries and the veins that we work around. And of course, during time of COVID, we always encourage everyone to wear a mask, but especially our potential recipients, because having COVID would mean that it would delay your transplant. Make sure that you socially distance appropriately, wash your hands, and be smart about germs in general. In terms of vaccination, everybody can get vaccinated, whether if you're waiting for a transplant or if you've already received a transplant. If everything is safe and we're all free of COVID, then we can get you transplanted. Now if there's any questions.
Thank you very much for the presentation. We're probably going to just get a couple questions right after this, our last participants. Okay. So next up, we're going to have Dr. Andrew Clark and his sister, Ms. Veronica Johnson, who Dr. Clark and Veronica will tell us about their story of transplantation.
All right. Good morning, everyone. I'm not sure. I still see the screen. I'm not sure if this is on yet.
We see you.
Okay.
I can't get in.
You gotta turn your video on.
Someone that keeps saying I can't start. The host has stopped it.
Okay, we'll work with the host. I'll contact the host, but Andrew, maybe you can just start and give your.
All right. So, actually, I'm Andrew Clark. My sister is Veronica, and she required a kidney. I think it was back in 1998, and she came down with a diagnosis with kidney disease. And I'm gonna let her go ahead and kind of tell the story. I'm gonna kind of filter in. Go ahead, Lo.
Okay, thank you. So I was in the military, and my legs began swelling one day. And from that, I was taken to the hospital and was diagnosed with focal segmental glomerulosclerosis, which is a kidney disease. A few years later, I was placed on dialysis, which was in 1997 at about 26 years of age. Then I spoke with my family, and we all decided that we would all get tested. They would all get tested, and Andrew was the one that decided that he would give me a kidney, and which was in 1998. And that was at the University of Maryland in Baltimore. My recovery time was about 3 days. I stayed in the hospital, and I was given a lot of immunosuppressant drugs. I also was given medication for hypertension, just to make sure that my levels stayed even. For that time period, I had a nurse that came in weekly and checked my levels, took my blood, made sure I followed up with my doctor. My diet was good, as well as I exercised. So I continued to follow that regimen for several years. I even had a baby at age 35, and I did well. My son is healthy. And then In 2013, I started losing weight. They checked my levels and everything, and they noticed that my kidney was rejecting. So about that time, I had the kidney from Andrew about 15 years. So by the time, I would say the end of 2013, December, they were scheduling me for another transplant, which they had let me know because I was so young that I would need another transplant to carry me through the rest of my life. Again, I went back to my family. We talked about it, and my daughter decided to get tested. She was about age 24, and she gave me a kidney. She decided that she would be the one that would give me a kidney. In 2014, I had my second kidney transplant. They did nothing with the kidney that was already there. As was spoken in the previous presentation, they just put my kidney up front instead of doing anything in the back. So again, my stay at the hospital wasn't long. Again, I went back to University of Maryland Medical Center in Baltimore, and they gave me the medication. Initially, when you're given the medication, it may be a lot, but then it starts to decrease as your levels level out, your blood work looks good. And the one good thing that I was surprised of is I no longer had the kidney disease of focal segmental glomerulosclerosis. They saw no signs of it. So I've had now the new kidney for 7 years, and I'm doing great. Thanks to my family. And I encourage everyone to please talk to your family about donating kidneys, even friends, because you can get a kidney from your family or just someone you don't even know or somebody you do know. Andrew?
So I want to say a couple of things. So again, my sister, I think you said it was 26, so I would have been like 27, 28 years old. And I can remember clearly, my sister was in the hospital one time and was not doing well. And I came into the hospital to visit her. And at that time, she was getting dialysis. And it was, something just struck me. And to see, this young lady at 26 years old, not being able to be really functional, being kind of bedridden almost, if you will, having to kind of to go back and forth to dialysis, I was like, that's not the way to live. And it was something that was inside me that really kind of compelled me, be like, okay, we got 2 kidneys. We could live on 1 kidney. It was just like, okay, then, I obviously did some research, talked to, the rest of the family and that type of stuff. And, made a decision to go ahead and go through with the surgery to afford my sister a better life, which it turned out. Now, as far as my life, now it's 98. It's almost 30 something years later, and I'm doing well, in good health. I'm 51 years old. Traditional, no real aches or pains or anything major, especially related to that kidney transplant or anything like that. Of course, you still have to maintain your traditional good healthy lifestyle. But there's nothing that's, I'm not debilitated or anything like that. You just have to be wise about the things that you eat, drink, sleep, exercise well, and take good care of yourself. Definitely, I think there's a big misconception in the African American community about transplants, and I think that as we as a people need to be more educated about donations, because I think that would help more people in our community, whether it be as simple as giving blood, or even signing up on a card to be, say, an organ donor, or something like that, because you never know if you're in a severe accident or like how many people you could actually bless if you're unable to survive an accident or something like that. I know it was a blessing to me to see my sister, like after she was able to recover from the transplant, to see her to go on to have a healthy life, and to give birth to a son. She had a daughter previously, but to then have a son later on in life, and to go on and have a prosperous career and just live life to the fullest and whatnot. I couldn't imagine how she would have been still on dialysis, or never ever receiving, or may not even have been here. So I encourage everyone to really give that a deeper look, and I encourage people to really reconsider the process of transplants. Do some research and find out more information about it, because you can really bless somebody. All right, thank you very much.
Thank you.
And I thank you both. I think that was a very powerful story, giving for living donor transplants. So at this time, we finished with all of our presenters, and there's just a few questions that have come up, and wanted to share a couple of questions and see if we can get Dr. Osman and Dr. Z and Dr. Varakis on, and all our panelists, to see if there's anything you have to add to some of these questions. So our first question, someone put in the chat was, is there an association with gout and chronic kidney disease? And I don't know if Dr. Osman wanted to handle that one. Is he still here?
Yeah.
Yeah.
I think I responded to that question. There's as much as I know currently, there's no fully conclusive connection, but as much we know, gout is a build of your uric acid, end up in small joints causing pain. However, the uric acid also has to be filtered by the kidney. So when you have this build up to an extent where a kidney is failing, you may have so much of that in the bloodstream stream that has to go through the kidney. It can do a couple of things. It can damage the kidney directly because it's toxic, and then it could cause kidney stones that may block urine flow from the kidney, and the urine can back up if not taken care of early. That can damage the kidney tissue. And if you have so much of this happening all the time, with the more kidney tissue you damage, the less likelihood that you're going to recover kidney function. So that leads to chronic kidney disease. And then, of course, you can have the crystals that might cause intratubular damage. That means that the tubules that drain urine from the kidney itself to the ureter, they could cause damage. By the time you discover that, the patient is kidney failure. If that is not taken care of in time, that may lead to chronic kidney disease. So, and then the drugs that people take for gout, like as I mentioned, indomethacin, ibuprofen, naproxen, taking too much of those also can damage the kidney by themselves. So there's several connections, directly and indirectly, that folks need to be aware of when they have gout and what medicine they take. Sure.
Okay, thank you for that answer. Dr. Z and Dr. Varakis, what about, we're talking about living donor transplants, and I've heard about multiple transplants occurring at one time for living donors. And can you kind of expand on that and how that can help to improve donation?
Sure. So probably you must have heard about the paired exchange program, where when you cannot directly donate to the one you want, so when you're not a good match, for example, either because a different blood type which is incompatible, or maybe there could be some antibodies that make it incompatible, then there are ways around it. So the main thing for someone to get off dialysis to find a live donor. So if direct donation is not something reasonable to do because of the risks, then you can get enrolled in the paired exchange program, where there are other pairs out there in the nation that cannot directly donate to each other. So you get in this kind of process where they're trying to match you with someone else. So you kind of switch kidneys. Your own donor would directly donate to someone else, and you're going to get a kidney from the other live donor. And sometimes, because there could be this kind of domino effect, there could be loads of donors and recipients involved in the same process. So one kidney, changes pairs, and everybody benefits out of it. In some occasions, an altruist donor, someone who's not donating to someone that he or she knows, can actually trigger this domino effect. And there are lots of people that can benefit from it.
Okay, very good, very good. So that's another way to increase the donation pool.
Correct.
Dr. Z, you mentioned skin cancer as one of the possible side effects. Are there any particular type of skin cancers with melanomas or what?
Yeah, so all types of skin cancer actually, there's an increased risk for all types of skin cancers. The two most common ones are basal cell cancer and squamous cell cancer, but certainly melanoma is the big bad that everybody wants to avoid. You have to, the recommended follow-up for skin cancer is actually yearly skin checks with a dermatologist, but your primary care provider can do that as well.
Very good. And as being an internist, yes.
Yes.
Yes. All right. So let's see. Let me give maybe two more questions. Dr. Osmond, dietary, people that have chronic kidney disease, as far as diet. And I know there may be a little controversy whether, can you expand on that as far as protein diet and low protein diet?
Well, I mean, when folks have a chronic kidney disease, the issue of a diet, like Riley said, is complex. One of the strategies we use to reduce progression is to avoid protein loading in chronic kidney disease, because sometimes people say I'm losing weight, and then they end up not eating calories, but a lot of protein. That itself, too much protein loading in the glomerulus, can damage the kidneys. So when there's, that's why we try to link them up with dietitians, kidney dietitian who can educate on how much protein, what kind of protein, especially from red meat, to try and avoid that as much as possible. So bluntly, we may tell somebody, if you want to eat protein, plant protein from fish and from poultry, reasonable. But forget about big steak, thinking that will help you, that may even cause damage further. Now, as you progress in the disease to failure, because people are malnourished, we tend to liberalize the diet a little bit more so you don't get malnourished. So you have to be very careful at what scale you are in the process of chronic kidney disease. At the early stage, we emphasize reduce low protein intake, not too low protein intake so you don't get malnourished. At the late stage, we kind of encourage you to eat more protein so you don't come to the end stage malnourished, which may also affect your prognosis.
Okay. Any follow up on that, Dr. Varakis? It's pretty much okay.
Well, I think Dr. Osman gave a very good explanation, so
sure,
we do agree.
All right, and I guess the last question, we're in a pandemic with COVID, and I know we stressed that, yes, social distance, do all the things not to catch COVID and also to get vaccinated. But people that have contracted COVID, what do we see? I know COVID can affect multiple organs. Are we seeing anything as far as the kidney is concerned?
Well, in the hospitals, I think some studies, some biopsies that were done post-mortem, they found COVID in the glomerulus. All right. Not only that, COVID is a multi-organ failure, when systemic failure, when you come really hit with the severe COVID. So that may be a domino effect leading to damage to the kidneys. It may be hemodynamic. It may be other causes of secondary infection. So there's so much when it comes to severe COVID, especially in intensive care unit. Because if you remember at the early stages, all the patients in New York, you heard about all those cases we need for severe dialysis before we understood the hemodynamic effect of COVID. So yes, we've seen a lot of effect of COVID on that. But when they end acute kidney injury in the hospital leads to chronic kidney disease on the outside. All right. So they may carry that effect as chronic kidney disease forward that may end up impacting them. Also, like we talk about high blood pressure and diabetes. If they had that complication of acute kidney injury that they recovered in the hospital from all the complication of direct or indirect from COVID, that may lead to future chronic kidney disease. So that's very important to note.
And I know I said the last question before, but if you can, one more question my line brother has asked. When neuropathy sets in for end-stage renal disease, can it be reversed with transplant?
When you've had it, it may probably improve, not reversed. Probably because you've had nerve damage.
Right.
It's not like diabetic neuropathy. You may improve it, but you cannot reverse it. I don't think so. I'll let the transplant surgeons, I don't know if you guys have seen any reversal. You may improve it because you have a normal kidney function now, but the damage has been set before you had the transplant. So
I do agree with Dr. Osman. It's more of a case of improving, and it's mainly pertinent to the kidney and pancreas transplant because we're talking about diabetic neuropathy. So when we transplant the pancreas along with the kidney for diabetics, then you can see lots of benefits in the long term. So you need someone to have this optimal pancreatic function for more than 5 years to start seeing some reversal of the symptoms. So it's a long-term process. I mean, the nerves do not heal very fast. Right. So you need to have good organ function for a long time, and then you're going to start seeing improvement.
Okay. Well, I think because of time, I think we've gone over a little bit on time, and I really appreciate the panel for coming on. Ms. Antoinette Corbin-Taylor, Dr. Clark and Sister Veronica Johnson, and all our panelists, the doctors, and also Patty Dash, who's the executive director of the National Kidney Foundation. I think there was some very important talk that we gave today, and hopefully we can have some further meetings in the future. I really appreciate everyone coming on. Thank you.
Thank you.
Thank you.
Thank you.
Thank you for organizing this.
Thank you.